Hello, friends. Today we will be talking about acute pancreatitis. What is the diagnostic criteria of acute pancreatitis? Acute pancreatitis is diagnosed with the three criteria, and among these three, if two out of three is present, then that is called acute pancreatitis. Okay, first of all, pain, and then comes lab finding, then comes imaging. Okay, in pain, the pain should be epigastric. Okay, typical pain of the pancreatitis should be epigastric, which is radiated to back. Okay, radiated to back. And in lab finding, serum amylase or lipase should be more than or equal to 3 times upper limit. Okay, upper limit. In imaging, we usually do USC ultrasonography, or in very less commonly, okay, we do CT scan as well. But mostly we rely on ultrasonography. If among these three things, if two is present, then that is diagnostic criteria for acute pancreatitis. After diagnosing acute pancreatitis, we have to find in which category do this patient fall. So we do severity assessment. Okay, severity assessment is done under three: mild, moderate to severe, and severe. Okay, mild pancreatitis is defined as when there is no fever. Okay, sorry, if there is no organ failure. Okay, if there is no organ failure, no local or systemic complication. Okay, moderate to severe means there is transient. Okay, transient organ failure, that is less than 48 hours. Okay, if there is persistent organ failure for more than 48 hours, then we call it as a severe pancreatitis. Okay, after knowing this, we'll do BISAP scoring. Okay, BISAP scoring used to predict how severe the pancreatitis is. Okay, and in BISAP score, we see BUN, is there impaired mental status or not, impaired mental status or not, SIRS is present or not, is more than 60, and pleural effusion. Okay, if BUN is more than 25 milligram per deciliter, then it will give 1 point impaired mental status, then 1 point SIRS, 1 point is more than 60 is 1 point, and pleural effusion 1 point. If among them, if the score is more than 3, it means that pancreatitis is severe pancreatitis. Okay, severe pancreatitis. After this, after finding how severe the pancreatitis is, we'll go towards etiological workup as well, side by keeping this in side by side. The common causes of pancreatitis are GB stone and alcohol. Okay. Apart from that, hypertriglyceridemia, tri triglyceridemia, and drugs are also common. Okay, if cholangitis is present, then we have to do ERCP urgently, within 24 hours. Okay, on for this etiological workup, we have to do USC abdomen pelvis to rule out any obstructive cause is there or not. We can do LFT to know its alcoholic pattern of LFT is there or not, like AST is to ALT more than 2 is to 1 is there or not. Okay, we can do TG, check TG, calcium, albumin, like that. Okay, so after this, we'll go to treatment portion. And what about the fluid resuscitation. Okay, fluid resuscitation is one of the most important thing in pancreatitis. First of all, type of fluid. Type of fluid. Iron is the choice of fluid in pancreatitis because it decreases CIP and it decreases the chance of sepsis or SIRS as well. Okay, and what about volume and rate? Previously, we used to give aggressive. We used to do aggressive fluid management. Okay, which means 20 ml per kg bolus followed by 3 ml per kg per hour. But these days we do moderately, moderate, moderate type of fluid resuscitation, which means we give bolus only if needed. Okay, if the patient is hypovolemic, only will give 10 ml per kg of bolus. If patient is hypovolemic, if hypovolemic, otherwise 1.5 ml per kg fluid is given per hour. Fluid is given to the patient of pancreatitis. Okay, and this aggressive fluid management or moderately aggressive management was studied in a study known as waterfall study. Okay, this is a randomized control trial done among these two groups, and they found that moderately aggressive fluid management is uh, more advantageous to the patient. Okay, after that we'll find out how the fluid is adequate or not. Okay, how to assess that? We monitor urine output, and if the urine output is 0.5 to 1 ml per kg per hour, then our fluid is adequate. Okay, if our hematocrit falls by 4, okay, after fluid resuscitation, then that is good. Okay, what about pain management? Previously, we used to follow WHO pain ladder. We used to go higher up if the lower group of drug did not relieve our pain, like PCM. After that, NSAID. After that, weak opioids, then strong opioids. We have to go from down to up in a ladder-wise fashion. Okay, and while following this, they also found that it's better to give higher group of drug like morphine initially to decrease the pain, because the pain of pancreatitis is much more severe. But these days we follow multimodal approach. What do you mean by multimodal approach? Multimodal approach means we give different group of drug at the same time. Okay, like PCM, NSAID if there's no AKI, and weak opioid, okay, like tramadol, we give at the same time. Okay, we do not follow pain later, we follow this multimodal approach. We give everything at the same time, so that this weak opioid will also be advantageous to us, and patient will have relief of pain. Okay, it decreases the higher intensity opioid like morphine. Okay, and patient will be less sedated. Okay, less sedated as well. Okay, this is the pain management in case of pancreatitis. After that, what about nutrition? Talking about nutrition, if a patient is able to eat, then we'll give by oral. Okay, if they are not able to eat by mouth, then we try to give them by uh, NG feeding will do. Okay, if there is no pain or the pain threshold is less, then we start giving them food. Okay, after that, antibiotics. Which antibiotics? Generally we need pancreatitis in acute pancreatitis. We need antibiotic which can penetrate our pancreas, like carbapenem. Okay, carbapenem, that is meropenem, cefepime, okay, piperacillin, piperacillin, tazobactam, cefepime or ceftriaxone plus metronidazole. For the indication of antibiotic in acute pancreatitis, if there is fever, increased WBC, increased CRP, there is gas in pancreas, which is seen in CT scan, or if there is positive culture. Okay, if we aspirate fluid from pancreas and if that's positive, then we give antibiotic. If there is biliary sepsis or cholangitis, we give them antibiotic. Okay, and if there is any other source of infection, any other source of infection, we do not keep we do not give antibiotic routinely. Okay, or that imaging like ultrasonography can be done initially, but because of gas shadow and many other things, we may not visualize pancreas. Okay, and USC is done basically to rule out any obstructive cause of pancreatitis, cause of obstructive cause of pancreatitis. Okay, and CT or MRI is kept to do at least we'll wait for at least 72 hours before doing this, because at this time we are more concerned about complication. Okay, complication, we can see complication via CT scan during this period. Okay, if we think of any complication, we do CT scan. Monitoring of a patient with acute pancreatitis usually done with the urine output. Okay, we'll do hemoglobin and PCB every 12 hourly. Okay, these are the two main things you have to monitor. Your output is range of 0.5 to 1 ml per kg per hour. Your output should be like this. Okay, and we have to watch for complications. We have to watch for complications like local complication. There can be local complication like necrosis, abscess, okay, pseudocyst, or hemorrhage. Systemic complication like shock, ARDS, renal failure, DIC. Okay, these are the complication we have to look out and be cautious. Okay, and this much for today about the management of pancreatitis. Thank you.